the UK and GASOC anaesthetic representatives, and I'll be hosting today along with Dr. Maria Kansenga, who's our international anaesthetic representative of GASOC, and she's an anesthesiologist in Zambia. So welcome to everyone present today. If you can put your questions in the chat box as we go along, we can then refer back to that when we come to the time at the end after the presentation. The session is going to be recorded today and then uploaded onto Medal for catch-up viewing afterwards. So if there's any problems with that, either don't put your video back on at the end and let us know if you've got any issues with that. And if you could turn your mic and your cameras off for the presentation, and then if you don't mind turning them back on after the presentation for our discussion time, that would be great, because then we could have more of an interactive time, like everyone's present in the room. So without further ado, it's my pleasure to introduce Dr. Joel and Tochie, an anaesthetist and intensive care doctor working in Douala, Cameroon. He's keen on evidence-based practice of anesthesiology. His major interest is suggesting new context-specific, adaptable, safe, and relatively cheap solutions in clinical anesthesia for resource-limited settings. Our paper today is the efficacy and safety of an adapted opioid-free anesthesia and regimen versus conventional general anesthesia in gynecological surgery for low resource and settings, a randomized pilot study. So thank you so much for speaking to us today. And without further ado, I'll hand over to you, and then we'll open up for a discussion time and following your presentation. Thank you.
Thank you. Thank you, Fiona. Thank you, Fiona, for giving us the floor. Thank you, everybody. Good evening to everyone. My name is Joel Tochie, anesthesiologist and intensive care physician from Cameroon. I work precisely in Douala, like in hospital, which is the major hospital in Cameroon. I was one of the hospitals in Cameroon in terms of its survival and the number of the head of department, the anesthesiology and intensive care. So he presents in a meridian as we begin presenting these our slides. So without wasting much of your So without wasting much of your time, our story is going to have the following outline. We begin with this plan, which shall be introduction with objectives. We'll describe our materials and methods. We'll present our result. We'll give a discussion, and we'll briefly give a conclusion. Then that shall be over for the day. To introduce our topic and the study rationale, or why we conducted this study within its context, because it's quite important to say this. Opioid derivative, fentanyl, removing alphentanil, sulfentanyl, the integral cornerstones of opioid-based anesthesia, general anesthesia or general conventional anesthesia. If we remember our formula for general anesthesia, we're going to need an opioid derivative plus a hypnotic, which can be an intravenous one plus an inhaled hypnotic, plus or minus a neuromuscular blocking agent, depending on if we're going to need mild relaxation to intubate this patient to control ventilation during the operative procedure, as well as if we're going to need mild relaxation for the procedure, for the surgical procedure itself. So the use of opioid derivatives during the period has not been without side effects. These side effects are quite numerous, and they have been commonly termed postoperative adverse effect of opioids. They include respiratory depression, postoperative nausea and vomiting, constipation, ileus, pruritus, which are all going to prolong the length of hospital stay going to cause poor patient satisfaction, as well as they're going to increase the financial cost of healthcare, which are all quite unacceptable today in the present era where we're trying to rehabilitate patients fast after surgery. We're trying to enhance or embark on the enhanced recovery after surgery protocol. So it is important to also see opioids. So using a lot of opioids during the perioperative period is going to cause hyperalgesia, pain chronization, which is going to lead to opioid abuse, and of course the famous opioid crisis or epidemic due to opioid addiction in the United States in particular, where in 2017 there were almost 500,000 deaths due to opioid addiction and abuse. To remedy to the situation of the side effect caused by opioids, opioid use in the perioperative period, some anesthesiologists came to remedy to this situation by describing or inventing a technique called opioid-free anesthesia, which is actually void of using opioid within the perioperative period. And it's a kind of multimodal anesthesia associating drug and technique for quality anesthesia. When we're talking about quality anesthesia, we're going to talk about good hypnosis, good analgesia, good sympatholysis, good anxiolysis, and good mind relaxation. And some of these drugs that can be used in opioid-free anesthesia, which are going to be calling OFA. For the rest of the presentation are going to be alpha-2 adrenergic agonists, lidocaine, ketamines, dexamethasone, and magnesium sulfate, just to name a few. But the problem with OFA today is that its efficacy and safety had been controversial due to mixed results from recent systematic review and meta-analysis. We're just going to show you about 4 systematic review and meta-analysis which were done recently between 2000 and 2022, both of them comparing opioid-free anesthesia to opioid-based anesthesia, both in general surgery. Here we have 2 randomized control trials, one by J. Frankench and the other one by Olasun, and the other 2 control trial, one specifically done in bariatric surgery and the other one done in thoracic surgery. We have this and we have that. And just as a synopsis of all these 4 randomized control trial, what did they find? They actually saw that the efficacy of opioid-free anesthesia is undoubtable in procuring good postoperative pain, reducing postoperative nausea and vomiting, reducing morphine consumption postoperatively. But the safety has been much doubted in terms of its hemodynamic profile within the intraoperative period. Some studies have shown that opioid-free anesthesia is going to cause more hemodynamic instability, bradycardia, hypertension, which are not quite good for the patient. And some of these side effects have mostly been used or mostly been related to the use of dexmedetomidine, which is quite one of the reference opioid-free medication. And so, because of this, the conclusion of many of these randomized control trial or systematic review, has been that well-powered address the problem of the safety of opioid-free anesthesia, and more precisely, perhaps with the profile of dexmedetomidine or without using dexmedetomidine. And so this study came to actually answer this question. One study carried out by Hélène Bellon in French. It was a multicenter study on non-cardiac surgery, and they compared dex-based opioid-free anesthesia to remifentanine opioid-based anesthesia, and they found that opioid-free anesthesia using dexmedetomidine, which is commonly called dex, is going to cause more postoperative hypoxia, delayed extubation after surgery, but especially severe bradycardia, which warranted the stop of the opioid-free anesthesia protocol. And the study was quite catastrophic because this randomized control trial, which actually entailed 214 patients, showed that opioid-free anesthesia was quite harmful for patients. So what is the context in Africa? and particularly in Cameroon, where I'm working. The problem with opioid-free anesthesia is that dexmedetomidine, which is one of the reference drug, like we said, is not available in Africa because it's not marketed, mainly because it is quite always relatively expensive. The other problem is that gynecology surgery is one of the most frequent surgery in our milieu in Africa and in Cameroon in particular. And this surgery is particularly prone to postoperative nausea and vomiting and intense surgical pain within the first 48 hours. So we ask ourselves, is opioid-free anesthesia, with all this merit of reducing postoperative pain, reducing postoperative nausea and vomiting, is it going to have an impact on gynecologic surgery if we use it? And if we particularly use it in a protocol which is void of dexmedetomidine. So we proposed this study actually as a randomized control trial. It was safe and effective protocol for opioid-free anesthesia not containing dexmedetomidine in gynecological surgery in resource-limited set. To carry out our study was first of all to determine the feasibility of our opioid-free anesthesia protocol. Determine its feasibility, that means its success rate. How many of our opioid-free anesthesia are we going to carry out without converting to general anesthesia or without adding more of opioid derivatives intraoperatively? Equally, we wanted to find as a specific objective, wanted to compare the frequency of intraoperative complication and intraoperative halogen consumption between an OFA group as well as an opioid-based anesthesia group. Then lastly, we wanted to compare the postoperative pain intensity and the rate of postoperative complication, be it postoperative nausea and vomiting, pruritus, urinary retention, as well as patient satisfaction and financial cost of our opioid-free anesthesia protocol as compared to our opioid-based anesthesia protocol. So to achieve this objective, we describe the following materials and the method. Firstly, this was a randomized controlled trial. It was carried out in a major tertiary hospital, which was a Modern Child Hospital in Cameroon, between January 2020 to 2021. As in the core period, we included all as 1 and 2 adult female undergoing elective mastectomy, abdominal myomectomy, abdominal ovarian debulking surgery, as well as abdominal hysterectomy for benign pathology, that's non-cancer surgery. We excluded all patients with past history of allergy to any of the drugs used for OFA or opioid-based anesthesia, any patient with planned adjuvant regional anesthesia, and those with iatrogenic surgical complication, in order not to add bias to our results. We use the following sample size formula. So according to this formula, we needed a minimum of 34 participants, 17 in each groups. We want to insist that we actually match patient for age and priority into an opioid-free anesthesia group as well as an opioid-based anesthesia group. We equally match them on type of surgery, we match them on the hazard grading. So in the preoperative period, what did we do? We obtained all the ethical approval we needed. We obtained patient consent, ethical clearance. We consulted patient where we randomized them using a simple randomization procedure in a ratio of 1:1 into an OFA group and an opioid-based anesthesia group. Data was collected to finally grade patient using the hazard classification. We chose our intraoperative monitoring devices, which was basically oxygen peripheral saturation, non-invasive blood pressure, ECG, temperature, just to name a few. And intraoperatively, we collected vital signs in the operating room. We compensated any fasting, any fluid fasting. We administered antibiotic prophylaxis, stress ulcer. We pre-oxygenated patient. And here now we describe now our opioid-free anesthesia protocol, which was basically lidocaine at 1.5 milligram per kilogram IV, magnesium sulfate at 30 milligram per kilogram, without exceeding 2.5 gram in 24 hours. This was diluted in 100 ml of saline and administered as an IV infusion to patient. We gave ketamine at 0.5 milligram per kilogram IV. Dexamethasone was given at 0.1 milligram per kilogram IV. Propofol at 1.5 milligram per kilogram IV. Rocuronium was given at 0.6 milligram per kilogram IV. This was what was used to induce anesthesia in the opioid-free anesthesia group, and then we proceed to endotracheal intubation, followed by maintenance anesthesia, where patient we put under volume control ventilation using isoflurane at 0.5 to 2% minimum alveolar concentration volume. Then we calibrated an electric pump syringe mixture at 10 ml to 15 ml per hour containing magnesium sulfate, still lidocaine, ketamine, and clonidine at the following doses you can see on the screen. We want to say this protocol was quite adapted. Our OFA protocol was adapted from a French protocol, which we described earlier during our introduction. For our opioid-based anesthesia protocol, this was just what was used for the induction fentanyl, propofol, rocuronium. Then we intubated patient. We placed them on volume control ventilation, still on isoflurane. Then we re-injected fentanyl, propofol as need be. Then patient was placed on an electric pump syringe mixture of a placebo of normal saline, set at the same speed. We now proceed to really describe what our study, what we're monitoring parameter intraoperatively. We monitor the respiratory rate, the oxygen saturation, the tidal volume, of course, the inspiratory-expiratory ratio, the PEEP, and the carbon dioxide expiratory concentration. Temperature was monitored. Intraoperatively, we equally resuscitated any hypotension, bradycardia, and high blood pressure. That was what we aimed for. And postoperative anesthesia was given 30 minutes prior to the end of surgery, paracetamol, tramadol, and nifopam systematically in both groups, both the opioid-free anesthesia and the opioid-based anesthesia. So, what was finally our end points which we wanted to study? The primary endpoint was the failure of opioid-free anesthesia, with a success rate of opioid-free anesthesia, which we define the failure as the need to convert to opioid-based anesthesia by either injecting or administering fentanyl, which was the main opioid derivative we use in the opioid-free anesthesia group. The occurrence of any intraoperative complication, hypotension, high blood pressure in particular, as well as the amount of isoflurane consumed in both groups. The secondary endpoint was measured within the first 48 hours of surgery, and this had to do with the pain intensity, which was measured on the numerical rating scale, the need of postoperative morphine, the occurrence of hypoxia, postoperative ALIOS, postoperative nausea and vomiting, the time taken for the patient to his first walk or to deambulate, the occurrence of pruritus. We equally evaluated postoperative satisfaction based on the quality of rehabilitation 40s questionnaire, and the financial cost, the mean financial cost of all the anesthetic drug used in the opioid-free anesthesia as well as the opioid-based anesthesia protocol was compared to know what was really at stake. Our results. So altogether, we approached 40 women undergoing elective gynecology surgery. Of these, 36 women were included. That was 18 in the opioid-free anesthesia group and 18 in the opioid-based anesthesia group. Both groups were quite comparable, given that they were matched on many variables, so they were quite comparable at baseline. In terms of age, their mean age was quite similar. Their parity was quite similar. The mean of the mean arterial pressure preoperatively, the mean of their pulses, of their oxygen saturation, as well as the type of surgery were non-statistically different statistically significantly different between both groups, apart from their mean body mass index, where we noticed that the opioid-based anesthesia group was slightly overweight or slightly obese, and the difference was pretty statistically different. Then we go to assess our endpoint immediately. We had 100% success rate for the opioid anesthesia group. So in our 18 participants undergoing opioid-free anesthesia, there was no need to actually use fentanyl or any opioid derivative intraoperatively. It worked, I would say, it worked perfectly well. And probably there was no intraoperative that was statistically significantly different between both groups. But we could actually see that in the opioid-free anesthesia group, there was no occurrence of hypertension, bradycardia, high blood pressure, but we noticed some few occurrence of hypertension and tachycardia in the opioid-based anesthesia group, but the difference was statistically non-significant. Then coming to the intraoperative complications, we aim to monitor the hemodynamic stability of our opioid-free anesthesia protocol compared to our opioid-based anesthesia protocol. And we decided to evaluate this by comparing the mean arterial blood pressure. And we can see that there was quite good hemodynamic stability in the opioid-free anesthesia group before induction, uh, at induction of anesthesia, 30 minutes prior to after incision, 1 hour after incision, and at the end of surgery, the opioid-free anesthesia group, the opioid-free anesthesia group actually had really good hemodynamic stability, as you can see on the blue curve, and this was quite statistically significant at 1 hour after incision. It was really quite low and more hemodynamic stable in the opioid-free anesthesia group. Still comparing the amount of intraoperative consumption of halogen, in this case we use only isoflurane. This is quite readily available in Cameroon in a resource limited setting, and it's also quite relatively cheap compared to sevoflurane, which is at times really scarce and also very expensive. So comparing the amount of mean alveolar concentration, the amount of volume of isoflurane we use, if we look again at our blue arrow, which represent our opioid-free anesthesia group, we see that it was quite, starting from 0.5 volume of isoflurane use, it was quite low all through surgery. It was quite low all through surgery, and this difference was statistically significantly different compared to the opioid-based anesthesia group. Then now we go to the secondary endpoint, which was mainly the pain intensity as well as postoperative complication. We measure our postoperative pain intensity by on the numerical rating scale, and we can see that the post pain intensity from the first to the 24th hour postoperatively was quite statistically significantly less in the opioid-free anesthesia group compared to the opioid-based anesthesia group. So the patient really had lesser pain at the first, second, 6, 12, and 24th hour postoperatively in the opioid-free anesthesia group. At the 48 hours after surgery, it was still low, but the difference was not statistically significantly different. Then the next secondary endpoint we sought to measure was the occurrence of postoperative respiratory depression, which we define as hypoxemia at an oxygen saturation, peripheral oxygen saturation less than or equal to 95% at room air. And we saw that at the first, second, and sit hour postoperatively, the oxygen saturation was really quite higher in the opioid-free anesthesia group compared to the opioid-based anesthesia group, and the difference was statistically significantly different. This last table actually gives a summary of other secondary endpoints that were measured, we can see that the mean total cost of drug use for anesthesia in the opioid-free anesthesia group was about £61, compared to about £90 used in the opioid-based anesthesia group, and this was statistically significantly lesser for opioid-free anesthesia. So it was quite economical for the opioid-free anesthesia group. There was lesser post-operative nausea and vomiting in the opioid-free anesthesia group. There was no pruritus. Patients were more satisfied post-operatively in the opioid-free anesthesia group, and there was less paralytic use. All this was statistically significantly different. So we'll go straight into just give a brief discussion because we've taken so much time already talking. We just want to discuss the pharmacodynamic property of the opioid-free anesthesia drugs. Want to talk about dexmedetomidine not used here, which has all of them. Talk about dexmedetomidine, clonidine, lidocaine, ketamine, magnesium sulfate, and dexamethasone. All of them are analgesic, that is for sure. But what is particularly good to emphasize here is that dexmedetomidine has good sedative properties as well as good sympatholytic properties. Clonidine also has good sedative properties, some hypnotic properties, as well as some anxiolytic and sympatholytic properties. Lidocaine is an analgesic, of course. It has anti-inflammatory properties, and has some activities against NMDA receptors. Ketamine has good hypnotic and sedative properties. It has strong activities against NMD receptors. So it's going to be quite important in hyperalgesia, reducing the occurrence of chronic pain after surgery, and reducing the need for patient getting into a kind of opioid overuse or abuse and ending up in what we call the opioid crisis or opioid pandemic. Dexamethasone, is an anti-inflammatory drug, of course, with strong anti-inflammatory properties. Obviously, it has also antiemetic properties. It has some sedative and anxiolytic properties. So we actually understand that combining all these drugs, clonidine, lidocaine, ketamine, dexamethasone, as well as magnesium sulfate, we're going to have not only analgesic properties, we're going to have hypnosis, we're going to have antiemetic properties, we're going to have anti-inflammatory properties of this drug, we're going to reduce anxiety, we're going to achieve hemodynamic stability through sympatholysis, and we're going to equally reduce chronic pain as well as acute pain. So this is actually the goal of opioid-free anesthesia. We'll go just fast to give some of the strengths and limitations of this study. We'll start by giving the limitation for a relatively small sample size of 36, which was actually due to the prevailing COVID-19 pandemic. During the time we conducted this study, makes it a little bit difficult to cautiously generalize our results. Secondly, we cannot also cautiously generalize our results to all resource limited setting, because this study was carried out in a tertiary mother and child hospital, a tertiary level of care hospital, level of care in Cameroon, where there was availability or rigid availability of an ECG machine, electric pump syringe, and clonidine intraoperatively. It's good to see that these devices, as well as drug clonidine, actually scales in primary and secondary level of care in Cameroon. And we guess this can be the same picture in other resource limited country or settings out of Cameroon too. The randomization technique we used was a single blind, which is not very conventional if we want to compare to double blind randomization, we think there are some selection bias which are present in our result. Then secondly, our study population was relatively young, healthy, non-obese study population, age 40 with the mean body mass index of 26. Most of them were ASA 1 and 2. So we believe that we did not really test all the benefits of opioid-free anesthesia, particularly obese patient, patient with respiratory handicap or insufficiency, like morbidly obese patient with chronic obstructive pulmonary diseases, the patient having chronic pains also, where opioid-free anesthesia has really been shown to have a lot of merits. But our relatively young non-obese population is quite justified because this was the kind of pilot study. It was the first time we're conducting opioid-free anesthesia in Cameroon. And we really wanted to be sure that we really put enough security on the patient side, on the anesthesia side, in order not to have any kind of perioperative morbidity or mortality, which may not be good for the patient. The main strength of our study was the fact is that we proposed a simple, practical, safe, effective, and economic opioid-free anesthesia, which can be implemented in resource-constrained environment like sub-Saharan Africa, where patients are relatively quite poor. We cannot overemphasize again on the necessity of safe anesthesia in a setting where there's already a lot of morbidity and mortality, not only linked to anesthesia, but also to the surgery and to the total preoperative period. So in conclusion, we're going to say that opioid-free anesthesia is a growing technique. Growing anesthesia technique is a multimodal anesthesia technique. Our protocol of opioid-free anesthesia we propose without dexmedetomidine, which is shown as a reference anesthetic drug, but which is actually scarce in Africa, in Cameroon, because of its relatively high cost, as well as the fact that it's not marketed. Our opioid-free anesthesia protocol not containing dexmedetomidine, associating lidocaine, magnesium sulfate, ketamine, dexamethasone, rate with few perioperative complications, including mild intraoperative hemodynamic changes, as shown with mean arterial blood pressure that was quite relatively stable in the opioid-free anesthesia group compared to the opioid-based anesthesia group. There was also a tremendous decrease and statistically significant decrease in postoperative complication when we're talking about the reduction in postoperative nausea and vomiting, reduction in postoperative respiratory depression, pruritus, ileus, and of course, patient had lesser pain and they had really low postoperative opioid consumption. So this comes to the end of our presentation. We're going to thank you for your kind attention. This is all about it. Thank you.
Thank you so much, Dr. Tosh, for that great presentation and quiet timing for the kind of study that you did, considering all the challenges that we've had in low middle income countries when it comes to access to some of these drugs. So when I was going through the paper, I thought, oh, okay, wow, these drugs actually do have, and if it actually a study was done as such as yours, who could actually work with some of those drugs to be able to carry out some of the surgeries for our patients. So we are just going to open for questions now. And I can see we've got some questions in the chat as well from a number of our clients or a number of people who have joined in. And I've got a question from Phyllis right now. Thank you so much, Phyllis, for having joined us. So the question is that, can you kindly comment on the rationale for the use of IV tramadol intraoperatively for both groups? As you know, tramadol also being an opioid. Yeah. I don't know what will be your comment on that, Dr. Tosh. The use of tramadol.
Now, actually, tramadol much, Phyllis, for your question. Thank you so much. Actually, tramadol is not really an opioid derivative. Tramadol is a second class analgesic. If we look at the WHO classification of analgesic, we have grade 1 or stage 1 analgesic, where we have paracetamol, we have non-steroidal anti-inflammatory, we have ketamine, we have nefopam. We have stage 2 analgesic, where we have codeine, we have tramadol. We have, that's basically it. Then we have stage 3 analgesic, where we have opioids. It's going to be morphine, opioid derivative. Tramadol is not really an opioid derivative, but nevertheless, tramadol was used postoperatively, not intraoperatively. It was used 30 minutes prior to the end of surgery, and it was continued postoperatively every 8 hours, given as an IV intravenous bolus, diluted intravenous bolus. So it was just as a normal, normal postoperative analgesic treatment, and it was given both in the opioid-free anesthesia group as well as the opioid-based anesthesia group, in order to have a kind of homogeneous population and to reduce any kind of bias we may have in results. Thank you.
I don't know if that is clear, Phyllis. I don't know if you've gotten that. So it used operatively and not
Postoperatively.
Yeah. Okay. So then the only other question is, when do we prefer to use nefopam? There was a question from okay, that was a question also
when
from
do we prefer to use nefopam?
Yeah.
Yeah. Okay. Thank you very much. Thank you, and Azi, for your question. Actually, nefopam could have been used. We did not use postoperative analgesic 1 gram every 6 hours IV, every 8 hours given intravenously. Then we have diclofenac. That's an anti-inflammatory drug that was given 75 milligram every 12 hours, either intramuscularly or intravenously, depending on the form we had. We had already 3 analgesics, which were quite strong. We could have used nefopam. We decided not to use it. We could have used it. It has its perfect place, but we do not also want to over-analgesize our patient to a point that, because already giving opioid-free anesthesia is good post-operative, intraoperative, and post-operative analgesia. Adding again these 3 analgesic, paracetamol, tramadol, diclofenac is good. In the opioid-free anesthesia group, fentanyl itself is a strong opioid. It's an opioid, and it's a good analgesic. And postoperatively, patient equally receive paracetamol, tramadol, and diclofenac. We could have used nefopam, but we thought associating the food analgesic would have been too much. So, nevertheless, you can use nefopam in your setting. It is not contraindicated, particularly if you're trying to anticipate on hyperalgesia, because one good quality of nefopam is that it is anti-hyperalgesic. It has a good activity against NMDA receptors. So it's going to reduce the phenomenon of hyperalgesia. It's going to reduce or inhibit pain chronotization, and patients are going to may require less opioid in future, as well as in the postoperative phase. Thank you.
Also, I think also in terms of availability, it's not all the centers that might have in our settings, I think, Dr. Tosh, no? So I think that is also, I think the drugs that were also used post-operatively for analgesia were also drugs that are quite readily available, I would say, when I was looking at that. They're quite readily available, yeah. So I think when it comes to nefopam, it might be a little bit difficult for centers that do not have those drugs. Yeah. Yeah. So then the other question was in terms of the contraindications for NSAIDs. So now the question is, now in the case where we have patients who where the use of NSAIDs is contraindicated, I think the question is, what can we do in that case? Because you are using dexamethasone in these patients, not so. And then later on, we have to use diclofenac post-operatively. Yeah. So now we have those patients where we are saying, okay, we are not going to use NSAIDs, if I get the question correctly.
Yeah. That's a very good.
Yeah.
Thank you, Maria. That's a very. I wanted to go to the slides on the pharmacodynamic properties of this drug. It's a very good question. Maybe let me just go first of all to the slide on the pharmacodynamic, if you may allow.
Yeah.
I want to say, dexamethasone and diclofenac can be switched. Dexamethasone credit, it doesn't change. It's not going to change much on your opioid-free anesthesia protocol. You can avoid it. It's not going to change anything much because if you have the other drug being constant, if you have ketamine, you have lidocaine, sulfate, and you have what else? Clonidine, plus or minus clonidine. Not going to change. What we actually want with dexamethasone is its analgesic properties, which I would say they will be negligible if we have the other drugs. If we have clonidine, we have lidocaine, we have ketamine, magnesium sulfate. But what we want more with dexamethasone is its anti-emetic properties. We know dexamethasone is used to actually prevent, not only prevent, but also treat operative nausea and vomiting at times. So, but it's good to see that in this opioid-free anesthesia regimen, it is not only dexamethasone that has this anti-inflammatory. Hello?
Yes, we can get you now. Sorry, we had lost you.
Well, I just want to say,
yes, we can get you now.
If you can get void of the dexamethasone, like lidocaine, because dexamethasone, you actually want to have anti-emetic properties. You want to reduce of post-operative nausea and vomiting. One of the side effects of opioids, fentanyl, remifentanil, sulfentanil.
Yeah. Yeah, so that was a good point on the point of having to use dexamethasone as an antiemetic. So because we are saying that one of course, the complications of our opioid-based anesthesia
What
is
you want with diclofenac is also anti-inflammatory as well as its analgesic properties. But looking also as other anti-inflammatories, we going to see lidocaine too has some properties. So if you're not using diclofenac because it's a non-steroidal anti-inflammatory drug, perhaps the patient.
I think we seem to be losing him, are we, at times?
Yeah, I think
we lost Joel again.
Yeah,
we've lost him again, I think.
Okay. What are the other questions that we haven't touched on just yet?
We've got just curious about the general duration of the procedures. Do you ever need to redose or repeat your infusion syringe?
Oh, cool.
That's
Joel,
from Jean.
do you want to tackle that, Jean? Joel, do you want to tackle that question? Fee, maybe tell Joel again.
So from Jean, Joel, it says, just curious about the general duration of the procedures. Do you ever need to redose or repeat your infusion syringe? We can't hear you. I think you're muted still.
Yeah, he's muted.
You're muted still, I think, Joel. Have you come off mute, Joel? We can't hear you. Yeah, Fab, thank you. Did you, so the question from Jean was...
what is the question?
The question from Jean was, do you ever need to redose?
About general duration of the procedure. Do you ever need redose, repeat? Oh, thank you. I've read the question. The question is, do you ever need redose, repeat your infusion syringe? Never. Oh, the syringes we use with a 60 ml syringe, and we mix this of a mixture of anesthesia protocol, ketamine, yes, and clonidine. So clonidine. We mix this. We brought it to 60 ml, and if you remember, we said we gave this at 10 to 15 ml per hour. 10 ml per hour. Most of our gynecology surgery, elective gynecology surgery, be it abdominal mammectomy, abdominal hysterectomy, ovarian, as well as mastectomy. Most of them, the surgery that lasted the most did not make more than 3, did not go above. So with the range being at 10 or 15 ml per hour, that's at least 5 hours is syringe for at least for a 5-hour duration procedure. So in the syringe, there was still some syringe before the procedure got finished. Just any redose, but rather in the opioid-based anesthesia group, if you remember, we said we constantly injected intravenously maintenance doses of fentanyl as well as propofol as need arise. Sorry.
That's great. Thank you, Joel. I think the other question we've got from Lionel is, did you have any wake-up delay?
Have wake-up delay coming from Lionel Chocken? We did have...
Yep. Have we lost Joel, Maria? Can you hear him?
No, unfortunately, I can't get him. Actually, I think
I can't hear him either. So I think we had a few more questions. I had a few, but I think if we can't get him back, we'll maybe wait for a minute and see whether we can get him back.
Yeah.
But just in the meantime, thank you so much to everyone for attending. In terms of feedback, you'll be sent an email, and if you can fill in the feedback form, then you'll get a certificate emailed through to you from Medal. And if anyone has any ideas of papers or speakers for our upcoming and journal clubs, then please let us know. In terms of upcoming events, so the next journal club from GASOC is on the 12th of September, and that one will be with a surgical focus. Our annual conference, so I'll just share screen, see if I can get the poster up, is coming up. So our annual conference is coming up on the 23rd of December. It's hybrid. In person is in Oxford, but there's also virtual options available, and it'll be for all those from LMIC attending virtually. The theme is health equity. So it'd be great to see as many of you there as possible. It should be a really exciting day like ours last year. Let's see if I can show you the poster. I don't know whether technology is being on our side tonight. It might not be coming up. Oh, it is. If not, then we'll have a look at our events on our social media. So that's the conference. The abstracts have now opened as well, so you can submit abstracts to present as posters at the conference. And finally, our Frugal Innovation Skills course is ongoing, and all of these events will be accessed through the Medal platform, and the on-demand content is also on there, so you can catch up at a later date. And keep an eye on our social media. And we were hoping that Joel might return. I don't know whether has he left or not. Was there any other comments from anybody else in terms of a discussion? Hi, Jan.
Hi, Fee. Let me try and contact him and see, and then we'll see what happens. He might just be back, I think.
Yeah.
And then he can answer all the questions.
Fab. Thank you, Jan. And Maria, I was just going to ask, in terms of in Zambia, do you tend to use any opioid-free anaesthetic regimes there for any particular types of surgery or patients?
Not if we can't help it.
No.
Yeah, not if we can't help it. Yeah. Yeah. Well, in terms of a crisis, of course, when we are trying to still get in some stock, we've had to use ketamine, lidocaine, and a combination of dexamethasone, but not because we wanted to, only because we're still waiting for some opioids to come by. And when they came by, of course, we used them. So that's why I said this is an interesting paper. I'm looking at things a little bit differently now. So
yeah. And in terms of,
yeah, we'll see how it goes.
In terms of the availability of drugs that Joel listed in the opioid-free and regimen, are they ones that are readily available in Zambia?
Yes. So everything there is readily available. Yeah. So both for the induction, the only one which we might struggle a little bit with was the ronchuronium. We are not yet having that. So already, especially in our public hospitals. I think our private hospitals have that, but our government hospitals not yet. So readily available. So
okay.
That's otherwise everything else was there. Yeah. Yeah.
Any luck with Joel, Jan, or no?
I've texted him. He hasn't replied, so I don't know what's happening at the moment. However, I think have we got a few more questions from the suggestion box? Then we can divert it to Maria and see if she can share some of her great inspirations. Did we talk about NSAIDs and PPI?
No, we haven't talked about PPI yet. That was the only one we haven't mentioned.
Cool. Maria, do you guys do NSAIDs? Do you do PPI for NSAIDs? Or NSAIDs?
I think you're on mute, Maria. Oh,
sorry. I was saying not as routinely as we would like to do it, just because of the availability of the PPIs. But when it's available, we do get to use it. Not just consistently, though, because it's quite erratic in terms of supply. So when it's available, we get to have protection for some of these patients. Yeah.
Cool. Quick question. Do you ever do GA sections?
There's a complication. Not, of course, we're doing them under Noraxil blocks. Otherwise, unless there's a complication with that.
Okay.
Then we end up doing
just
GA.
So, because in England, obviously talking about HIC context, we tend to give them pre-med. So that will be a PPI and a I can't even remember what metoclopramide is, sorry, because it's been a long day on neighborhood. But yeah, and we tend to give pre-meds for everyone for section, not only GA, but also for spinal, so long as they were like Cat 1, Cat 2. That's not really the case. But maybe we're throwing too much at the bandwagon. Don't know. What do you think? Fiona, have we got any more questions? Do you think?
I mean, I had a few questions particularly, so really ask much. Do you have much experience, Jan, in your institute of opioid-free anaesthetics? I know we've had a couple consultants like it and down here, but
not totally opiate-free, but more like opiate-light is what people tend to do. So if I can get away with most things with a block with a spinal, then we go ahead and do it, and then we just try and be opiate-free. The other thing that we normally do, so like I can do a good block. So we do a fair amount of ultrasound-guided regional around here, big fractures, rib fractures, that kind of thing. So it's more in the Jerry's, the octogenarian population, that we tend to go absolutely gung-ho about opioid-free. But the others, it is up to what's happened and whatever is happening around. It's more in the day and age of TIVA. I do notice I don't give any long-acting opiates in our institutes, but I won't say opiate. Well, I call Remy still opioid, so it'll be some Remy on board, and then see what happens post-op, and that's pretty much what we normally do.
Lovely.
You guys,
have we got Joel back? I think Joel back, is he? I just saw him pop up again, but maybe he's not.
Yeah.
Hello?
Are you there, Joel? Oh, hello.
Yeah. Hi. The network was a little bit messy, sorry.
That's okay, don't worry at all.
Okay.
I think the last question we had was talked about the PPI one. I mean, I was just interested in knowing, since you've done this study, have you adopted it as your practice in this and subpopulation of patients? And have you noticed any ongoing changes? Did you hear the question, Joel? Did that come through or not?
I'm sorry. Thank you. I'm sorry, Fiona. The network is very bad. I'm not really heard your question clearly. Is it possible for you to type it down?
Yep, of course.
No, I did not get your question very well. The network was a little bit a mess. Is it possible for you to type your question down? It will be better for me to
I'm just typing it now.
Yeah. Answer, please. Yeah. I'm waiting a question from Maria. Maria, I need a question. I'm waiting a question from John Wong. So, question from him.
I've just typed mine in the chat. I don't know if that's coming through.
Not yet. Where is it? Oh. Okay, cool. Since doing this study, have you adopted this in your practice in this group, and have you noticed any ongoing change? Yeah, thank you for your question, Fiona. Actually, we adopted this I have to really admit that this study was done as my end of dissertation for my specialization as an anesthesiologist, intensive care physician. It was done here when today I'm in Douala. So the two biggest cities in Cameroon is Yaoundé, which is the political capital of Cameroon, and Douala is like the economical capital. That's where it's booming. There's much more on the rest than Yaoundé is more of a presidency and it takes many things. So this study was done in as an anesthesiologist, and I've carried it to Douala, where I'm practicing today. And I bet you we do it almost for all the procedure. We do it ENT surgery, amygdalics, who moves to urologicals that need moves to thoracic surgery, and we'll just see it is working like mad. Actually, I'm doing a little recruitment and a little study right now on the benefit of this protocol, particularly in pediatric surgery, where there are few studies on it, and surgery too, where there are few studies on it. So we really see what can be the opioid good is what well using it in practice, and it is working.
I think we've lost him again, haven't we? Fab, Joel. Thank you so much, and thank you so much for taking the time to present to us this evening. It was going to be my next question. Actually, was what studies you're planning on doing. So, but thank you so much for joining us, and yes. And thank you everyone for joining us online. And yes, hopefully we'll see you for our next journal club or at the conference coming up in the autumn. It'd be great to see you there. All right, everyone, take care.
We use in